Welcome back to Beauty and the Surgeons. Dr. Martin here, Dr. Jason Martin. I'm a board-certified plastic surgeon with Amy, who is a nutritional therapy counselor, certified nutritional therapy counselor, and we have a really, really good guest today, in-house.
Very intriguing, good guest.
Dr. Adam Lowenstein. He's also a board-certified plastic surgeon, which I don't know how much that gets you, but these days I'm proud of that. You're proud of that too.
I'm proud of it.
Yeah,
Yes.
he has a practice like mine. He's actually from Santa Barbara, and he is now expanding his practice into a really, really interesting new component or a new facet of plastic surgery, which is headache surgery. He's the owner and creator of headachesurgery.com and migraine surgery specialty centers. He's also, you can be followed on Instagram and YouTube and other things like that, as Migraine Surgeon. So welcome, man. Thanks for coming in.
I'm real happy to be here.
All right, so you're a plastic surgeon. That's great. You do basically what I do, which is more cosmetic surgery, but you've recently expanded your practice into a different field. Can you kind of go into that real quick?
So I've had a kind of fascination with migraine surgery ever since they kind of came out with it in 2000. Dr. Bauman Gairon did some work on it. His brow patients noticed that his brow patients, a lot of them didn't have, were cured of their migraines. So I've had migraines all my life, and I've got stories from my mother when I was 7 years old that I had really bad headaches. Yeah, I'm all right. And so I've been very interested in this for a while, and then really decided to kind of pick up the ball and run with it. And it's been great. It's a matter of doing microvascular decompression of peripheral nerves. So they're not the nerves, not in the brain, but nerves in the head and neck region, and releasing those nerves, which is actually preventing the triggers from causing the migraine cascade that really causes all of the pain. So it's fun, and it's extraordinarily rewarding. Our patients are just incredibly grateful, and it's really changing lives. So I'm really enjoying it.
You know, in researching for this podcast, when Amy and I were looking at it, the incidence of migraines in the United States is alarmingly high.
And lost wages and just quality of life issues. Like
Billions of dollars
Yeah.
it affects our economy, and these people suffer immensely.
It's to a person, my patients always tell me afterwards that the fact that they can re-engage, it's if you don't, first of all, if you've never had a migraine, it's really hard to understand what that is like. Okay,
What is the difference between like just a headache and a migraine?
So migraines, number one, have associated symptoms with them. So like we call them auras. They can have visual changes, and this can range all the way to hemiparesis. Okay, so patients like lose ability to move. And feel parts of their body. That's
like a stroke. Kind of like a stroke.
And it's actually frequently confused with a stroke initially. And so nausea, and I'll be honest with you, I had a migraine this morning, okay? And so like I woke up this morning and my entire body ached. My head was pounding. I was very parched. And for me, again, I've had various types of migraines all my life, and I can control my migraines with what's called a triptan, which is a type of migraine drug. And so I took some of that this morning, and now I'm back to myself, for better or for worse. Again, if you haven't had this experience where it just all you want to do is stay in bed, light bothers you, sounds bother you. I mean, I was telling you earlier that I'm staying at a hotel that has very fragrant soap, okay? Smells are a very frequent trigger of migraines. So these people walking down the street, they're fine. Somebody walks by with a bunch of perfume, it can ruin not only their day, but their week. I mean, that can spiral into something where you're incapacitated in a room trying to stay quiet and dark, and I mean, it's really incapacitating.
So it's a headache, but it's a headache with a lot more severity, number one. And secondly, there's usually associated symptoms with it that are above and beyond what you would have with a headache. And third, at least with migraines and doing the research for this, it's usually in certain types of locations or the trigger points associated with migraines, which we will get into, separated out from a normal headache too. This kind of gets us into your backstory that you and I were talking about, which makes it so interesting. So this podcast is primarily about education, empowerment, and transformation. And a lot of things we talk about are plastic surgery, which you and I do on a weekly basis. But we also talk about stories of transformation. We also talk about educating yourself and empowering yourself. And you have a really amazing backstory as someone who has struggled with migraines their entire life. And I want to go into that and talk about that. And then you dovetailed that struggle, okay, into your surgical career to help people like yourself to transform, to get better, and to empower them to actually have an answer to this problem. Yeah. Which, by the way, a lot of people can be controlled by medication, according to the data, but some people can't. And if you can't control it with medication, you're really at a loss in this world the way it is now. And that's what we'll get into. But let's go into your backstory real quick. So, where'd you grow up?
Maryland, outside of D.C.
Okay. And you were talking about your mom. She's a psychologist.
So my mom is a PhD psychologist, and when I was a kid, she was a school psychologist. And we lived in a place called Bowie, Maryland, which is a fantastic place to grow up. But she got her PhD at University of Maryland. And I'm not sure which part of this backstory you want, but the story that I tell frequently is I watched her write her thesis, which happened to be on only children of single parents, which is me, right? So basically, she wrote her thesis on
being a single mom.
Yeah, her life.
It was her psychology thesis.
Yeah.
So, and I joke around that I would come home from school and all the other kids were watching TV and doing all this kind of thing. I was taking a Rorschach test.
No pressure.
What does it look like today?
Yeah, no pressure.
Well, I always kid around that I knew the answer book, so I could make you think. If I took your Rorschach test, I could make you think I was a pathologic killer or a very empathetic. Is fun.
You could
anyway,
manipulate the test.
Yeah, there you go. So, so when I saw her do her thesis, our dining room table was a little smaller than this table, and it had piles and piles of books, and it looked so hard. Like for years, she had all of these books. She was doing this research on the dining room table, and I always thought, I wanted to be a doctor, but I didn't want to go through that. That looked hard. So medical school's got to be easier than that. So that's I wanted to be Dr. Lowenstein, and she was Dr. Lowenstein, and that. But in fact, I never actually thought about doing anything else except being a doctor. So that was that's growing up. That was.
Did you know you wanted to be a surgeon, or just?
So I'm an only child.
Hence the thesis.
Hence a lot of things in my work. Hence
no pressure on you to succeed.
My practice.
Your poor wife.
Solo practice. Yes, that's right. She'll be happy to watch this and get some empathy there. My surgery center is solely my own. I like what I like, and so yes. And in.
You said in high school that you were very intelligent. You finished early, and
I didn't say I was very intelligent.
Oh, okay.
No.
Well, I got it from your story. Okay, that you finished a year early.
You make your
in
own
high school.
assumptions. Yeah. That's fine.
All right, we'll say that you were kind of smart. You finished a year early. You only had one. It sounds like one credit left, and then you actually went to the children's hospital near you, and actually did research in trauma.
Yeah.
Was it trauma?
Pediatric trauma.
Yeah.
Right. So, in answer to your previous question, I'm an immediacy guy. Like I don't my email is empty, right? I don't have any pending stuff, right? And so I'm not really good at taking care of blood pressure, giving you a medication. You come back in a couple of weeks and we'll see if it worked. I want to fix things at the time. So that's kind of how it I had an affinity for surgery. But when I was in high school, I had an opportunity to get some extra credit outside of school just because I had to do something the rest of the day, aside from taking my English class, which was the only thing I had to do in my senior year. And so I found this internship with a guy named Marty Eichelberger, and he was the trauma surgeon at Children's in DC. And so I started working with him, and we got some papers published with my name on them before I left high school, and I got to go into the OR with him, and I was just fascinated with all of that stuff. And so
That probably hurt you with medical school that you got a paper published in high school.
yeah,
Right?
that was
And you didn't always
with your
spend time
admission.
in the ER or in the OR.
And there's not many applicants that are getting papers published when they're in high school.
I guess it didn't hurt.
It didn't hurt at all. Yeah. So you were motivated from the beginning. Your mom was a great motivator for you also to see
Influence,
what she
yes,
influence.
great
Yeah,
influence.
to what she had done in her life as a single mom and risen above and.
Yes, aside from the fact that she raised me alone. Which
Yeah,
is,
exactly. But then
deal.
she became very successful in her own right as a psychologist
She is, yeah.
in the DC area. Then you went to college, and we'll skip over the undergrad years because we all have stories from that usually aren't related to medical school or surgery. From undergrad, you went to medical school. Where'd you go to medical school?
Chapel Hill, North Carolina.
So Tar Heel. Dean Smith was the coach then, is that correct?
Dean Smith was the coach then.
Okay.
And as you all know, tonight is the biggest sporting event of the year in the country. Right?
Which is Duke, Carolina,
Right,
which
Duke.
I would argue is not the biggest sporting event. Secondly, this is a podcast that comes out at a certain time.
Okay, well, I'm just saying.
So we're not trying to date it.
Yeah, all right.
Whenever this podcast comes out, we did it right then. It's
Okay,
live.
Fair enough.
Okay.
All right, sorry.
So you went to UNC, went to medical school, and when we were talking, it's just you have such an intriguing story. You basically stated, and if you could go into this, that you started having headaches around 8 years old. Is that correct?
Yeah, I mean, 10% of school-age children have migraines, and I was one of those lucky people. And I don't really remember so much, except I do remember that back in the day there was Anacin, right? Which I don't know if that exists anymore or not, but I used to take a world of Anacin, which is aspirin, to the point that I became allergic to it. Right? So I think allergic to it as in you're in the emergency room with EpiPens and your throat closing off. So I used to take a lot of aspirin as a kid. But it doesn't, the issue with migraines, a lot of times these over-the-counter remedies, they don't work. And so, we'll get to this in a little while, but I had a migraine. For me, one of the triggers is stress, right? And so we both went through general surgery residency, which is stressful.
I would say that on a level of 1 to 10, it's probably about a 35.
There you go,
of
right?
stress.
So I went through my general surgery residency with about an 8 out of 10 headache.
Right, so I want to make this real clear. So you went through medical school and general surgery, which medical school is very difficult, very stressful. We all had stress during that time. It's pretty extreme in terms of what they require you to do. And then general surgery doubles down on that. And then it's in some ways malignant, and it's the word we use, which means they don't treat you very nice. It's like the Army. And during that whole time, you were struggling with migraines?
Right. And to the point that nothing I couldn't take aspirin anymore because I was allergic, but Tylenol, Advil, nothing helps, right? So that's one of the issues with migraine. You have to take certain medications which may or may not help, and but over-the-counter stuff tends not to. So,
Which kind of makes sense. I mean, over-the-counter anti-inflammatories like that they're working with your prostaglandins receptors. And if it's not an issue of inflammation that's triggering a migraine, then it would make sense why that wouldn't really be effective treatment.
And there's lots of different kinds of migraines, and there's lots of different. It's really an evolving field And it's not an evolving field in plastic surgery. It's an evolving field in neurology. And thank goodness for the neurologists, because they are, there's new drugs coming out even this year that previously haven't been available. But the reasoning for migraines has been thought variably that the blood vessels in your brain swell and dilate, and this causes issues. So some people will take medications to cause those blood vessels to get smaller. Obviously, those kind of things are not over-the-counter medications, right? And so, there's cascades of neuropeptides that, are now these new medications are monoclonal antibodies against some of those things. But point is, very, very kind of esoteric, specific medications that need to be used for these patients. And a lot of these medications work really, really well for a lot of people, but there's a subset of people who they don't work well for.
Right.
Yeah.
For you going through this, when did you? So I mean, you lasted through all your training and remarkably did very well.
Well, I mean, I'm not sure how well I lasted.
Yeah, well.
I gotta tell you that I call myself a nice guy in recovery. Right? Like, I was a very, very sweet kid, and then I went to my residency.
Yeah.
And
so that's pretty much a commonality for most people to go through
Yeah.
it. But for you to have to deal with the added component of physical pain,
it was very
you would have to
unpleasant.
be an extremely strong person to be able to get through that kind of training process. And as you said, you're a doer. Like, you don't like to have the open emails in your inbox and stuff. And thank God you were that way, because to be able to have the inner strength to rise above that and get through it, put one foot in front of the other, kind of a common theme we have in our podcast. And you did it. So then you made it through, became a plastic surgeon, did what plastic surgeons do, and we all go through training and we get out. And some people join practices, some people join hospital systems. What did you do when you got done?
So when I was done my residency with my plastics residency, I actually came out to Denver and joined Kaiser Permanente, which I think is arguably the best job you can have right out of residency, because I was doing like complex cleft lips and palates. I helped separate conjoined twins in my third year of practice. I mean, you don't get those kind of opportunities just out in your own practice. So I was there for 7 years doing microsurgery and a lot of breast reconstruction and craniofacial stuff, and it was great.
Right, and the microsurgery, just for people to understand, is surgeries with a microscope, and that's really dovetails into the headache surgery that we're going to be talking about here soon. So you were there, and then somehow you ended up out in California, in Santa Barbara, which we have a practice in Aspen, and everyone's like, oh my gosh, I can't believe you have a practice in Aspen, but I think Santa Barbara may trump Aspen.
Oh, yeah, I think so.
I mean, it's not even a competition.
It's not a lousy
Yeah.
place.
Yeah.
It's not a
It's
bad
not a
place
lousy
to be.
place.
You
I
wake
mean,
up in the morning, you're like, oh, life is so wonderful.
Like,
you
there's
know?
the ocean.
There's birds coming
Yeah.
by, people are smiling and jogging.
Sun is shining.
Yeah, and everyone that lives in the East Coast is just miserable, and they just hate you for the fact that you have a practice in Santa Barbara. But you've made a name for yourself, a very talented surgeon. I know that. I came in contact with you through the American Society of Plastic Surgeons. You were on the board. You were head of the Young Plastic Surgeons Organization, which is part of ASPS. You were part of the mentor board, I think, at one point, in terms of the implants. A very successful surgeon, cosmetic surgeon, oriented primarily, and yeah, everything's going well. And then all of a sudden, I'm talking to you on the phone, and you start talking about headache surgery. And here's a person that has it all inherently, with where they're located, with the practice and everything, and you're talking about headache surgery. And in some ways, I was like, what's Dr. Lowenstein talking about here? He's a little bit crazy. But
Well, that's justifiable.
yeah, that's
right?
justifiable.
Yeah.
But I do think it's important to note that your interest in headache surgery really kind of goes back to all your experiences throughout training and also your personal experiences. You were micro-trained, a very successful surgeon, very talented, and you saw an opportunity to help people like yourself, then also use your surgical talents that you inherently have from your training and your private practice.
So I'm not sure this is probably not what you're getting at, but I will say this about what we do. plastic surgery is a very, very diverse field. Like, and not a lot of people know that, for example, the first transplants were done by plastic surgeons. So the pioneering spirit of people in our field is great. And so I've had a really great opportunity in my career to kind of reinvent myself several times. Like, I did reconstruction here in Denver for many years, and it was fantastic. And then I thought, okay, well, what's the next challenge that we can look at? And so when I left Kaiser, and again, it was fantastic practice, but I'm an only child, and at the end of the day, after a period of time, I'm kind of better off making my own decisions and on my own than in a big company, which is why I decided to leave Kaiser. And I ended up in Santa Barbara, not even knowing where Santa Barbara was or what it was like initially, but I got lucky and I ended up there. And I got to train there with one of the top aesthetic surgeons. And as you know, a lot of fellowships for aesthetic surgery are, 3 months to maybe a year. I got to work with this guy for 3 years all the time, and basically did a 3-year aesthetic fellowship. And then he retired and I took over his practice. So then for the last 10 years, I've been doing aesthetic surgery. It's great, love it, it's a lot of fun. But kind of thinking, okay, well, what's the next challenge that I can look at? And so this headache surgery just it seems to be a great opportunity. It fits with my world because, again, I've had these issues. I can identify with patients, and I think a lot of patients really appreciate that because, again, if you haven't had this, you don't know what it's like. And so it's really, at the end of the day, I'm just very, very lucky to be doing, what I'm getting to do in the field that we're both in.
But we don't, in this podcast, we don't believe in luck. I mean, you have circumstances, and then you have an innate ability to understand those opportunities and take advantage of them. And when I say take advantage, I don't mean in a way that's manipulative. I mean that you utilize all your experiences in life. You were fortunately a good surgeon at the right time. You were very well connected and respected, so you came into contact with Dr. Gurion or Janice or all these people kind of working in this field, and you were able to reach out and implement that in your practice, and you should be commended for that. But more importantly, we need people like you in our field. We need people to reach out and grab some of these novel surgeries and to keep expanding, to keep on trying to improve the health of people, from a plastic surgery standpoint, but in this case, from a functionality standpoint.
Quality of life.
Yeah. I mean, that's the biggest issue with what we're doing is quality of life issue.
Mm-hmm. And I can absolutely see that. I mean, I've never had a migraine, but I can definitely understand having spoken to people who have, that it can take a while to be understood. That there's so many symptoms that can add to it, and it can kind of they get so deep in their treatment or in their lack of treatment that people stop believing them. They think their symptoms are fake. So going to someone who's experienced those symptoms and knows that they're not faking it, they're not, making these up.
At the very least, can be compassionate.
That's what I mean. Yeah.
Relate.
Can understand that. These symptoms are all real. Like they're in your head, but they're not in your head.
Yeah, I mean, a lot of people get a social stigmata about them from
Missing
having
work.
migraines,
Yeah.
and a lot of people lose their job because they can't function at work, and sick days turn into one after another, and you don't have an understanding boss, or you can't do your job. And then, these people really, it can ruin people's lives. I've had patients tell me that they were considering assisted suicide, right? And we operate on them, and then they're like, I haven't felt this great in years. And it's just, you hear that from somebody, and
you can't. I mean, it fills you for the rest of your life.
Exactly.
Yeah.
Right.
So, all right, let's get into it. So if people have migraines or migraine sufferers, what do they usually do first? They go see a neurologist or get referred to a neurologist?
They usually go to their own doctor.
Okay.
And then their own doctor will often send them to a neurologist. And, from there, so many different things can happen. You can go to headache specialists, you can go to pain doctors. A lot of my patients are seeing multiple physicians, and there's so many different ways to try and attack this. And a lot of people, they'll get, one of the things that we get is we don't get, the neurologists get, is an MRI of the brain, because at the end of the day, you want to make sure that there's nothing else going on, right? So you want to make sure there's no brain tumor or anything like that. So then you get people who, they're looking so hard for a reason that this is happening, and they get an MRI and their brain looks normal, and they're crushed, right? Like, I was hoping that there was going to be a tumor there, right? But that's normal. And then it's, how can we attack something that we can't see? It's, the problem is right here, or it can devolve into a whole, I'm seeing this person for my narcotics, I'm going to see this person to get a nerve stimulator put in. That's one of the things that some people do. I'm going to see this other doctor for meditation issues. A lot of these things are successful. Like, a lot of people will do, there's something called a daith piercing. You know what that is?
Yes.
Right?
Yep.
And so a lot of people will get a daith piercing, and it helps them with their headache, which is awesome.
I didn't know there was a
right?
correlation there.
Yeah. So, people say to me, should I go get this piercing? Absolutely. Like, lots of different things work for lots of different people.
So that's like on the theory then of like Eastern medicine, that it's somehow like disrupting your chi in that area?
There hasn't been any studies. There's a lot of discussion about this, and it doesn't work for everybody by any means, right? So a lot of people said, yeah, I tried that, it didn't work. But it's not really understood. And that is part of the problem, is that migraines are not completely understood. And so, it's interesting that when, in all of these doctors that you would see with a migraine, the plastic surgeon is about the last guy on that, on that list. And
so for like the patient with a migraine, what percentage does first line treatments really work for them? Like 80% or 70%?
First line treatments, I would probably
medications.
say ballpark around 50%.
Okay.
But then there's a tiered thing of
Yeah.
going to one thing and then another thing and then another thing. And
you're literally at the end of the rope.
yeah, I mean, so look, I love the surgery. It's awesome, right? But it's not for everybody. If you, I haven't had the surgery because I take Zomig, which is a type of triptan. And I can function on Zomig. Like, Zomig wipes out some people. It makes them so exhausted. But you and I have had 5 days of operating straight without
Right.
eating or sleeping, and I'm kind of used to that. So
Hard to
that
keep a
side
good
effect,
surgeon down.
yeah, it doesn't bother me. I'm
Won't
used
stop,
to it,
can't
right?
stop.
Yeah, there you go. So, but some people can't take that type of side effect. So Zomig doesn't work for them. But a lot of people can. And so the point is that if daith piercing, medications, nerve stimulators, if these things work for you, that is awesome. And that's really the thing to do. You only go to surgery if nothing else works. But in those patients where nothing else works, and we can do some of our screening tests, which I'm assuming we'll talk about in a little bit, the efficacy or the ability for this to actually work is extraordinarily high. And so that's a great thing.
Right.
Are you seeing an increase in the number of people who are finding out about the surgery and actively seeking you out?
That is a hard question. Are we seeing an increase? And there more people know about this today than yesterday than last week.
Mm-hmm.
Okay, but today hardly any people know about this.
Right. So
right?
15% of all Americans, 35 million people, right? Migraine sufferers.
Oh, right. Yeah.
50% of those, the first line therapies, the drugs and stuff help out. And then you do the CAM stuff or alternative treatments, all these kind of things. I mean, there's millions of people out there suffering from migraines that are not totally getting relief or even functional improvement with all these therapies. And in reality, the surgery has a lot of potential, at least from the data that's out there.
Yeah, I mean, the data that's out there is, is very favorable. My personal experience is very favorable. But the biggest problem with migraine surgery is people don't know it exists.
Yeah.
Right. And honestly, we also have a reasonable amount of difficulty with getting people to refer to us because, as kind of talking about earlier, the neurologists, I think they feel similarly, like the plastic surgeon's about the last person you need when you have a migraine, right? And so for a plastic surgeon to go to a neurologist and say, I can help people that are at the end of their, who the subset of people that are not getting better with what you're doing, I may be able to help. They're skeptical, right? And I can understand that because, look, if I was a neurologist and said,
look at my plastic
Dr. Martin,
surgery research.
I have a great way to
Right.
do a facelift. You should look at it.
Right.
You'd be like, come on, man,
Yeah.
right? So I totally get it, but it's on us to get people the data to review and actually see the success rates, which are better than 90%, and that's part of what we're having to do right now.
I mean, the data, I'm sorry, just real quick, the data goes back 15 years, or more than that, 18 years now almost. And it's robust data. I personally looked at it. I highly advise people who like that kind of stuff to look into it themselves and see that these are real studies with larger numbers, statistical significance that is formidable, and an efficacy, and we can go into that, what that means, but an efficiency or an improvement that is really there.
I mean, I don't know how. So Dr. Guyron in Cleveland is kind of the father of all of this, and his first study used sham surgery. Right? I don't even know how you get that passed through the IRB.
Right? How do you get
right?
an approval to put
so
somebody to sleep? And do
half of the
nothing?
patients
If you're
go
at the
to
Cleveland
sleep.
Clinic or Mayo Clinic, you can do what you want.
Maybe, well, and
Yeah.
Dr. Guyron is Dr. Guyron.
He's the
so,
man.
he is a very, 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 very well-respected plastic
Probably
surgeon
the
in
most
the world.
well-respected,
Exactly. So, but I mean, he put people to sleep, made incisions, and in half the people he went and did the decompression, and in others he didn't do any decompression.
Centered it back
And
up.
so, right, and you can see, I mean, that's as strong a study as you can possibly do. And when you see huge statistical significance that the people who got the surgery largely got better, and the people who didn't, got the sham surgery largely didn't get better, it's not vague, right?
What percentages are we talking about here in some of those studies? And I know it depends on the site. We'll get into it more in detail. But what percentage are we talking about?
So, when we talk about improvement, we're looking at, there's a subset of patients who never get another migraine, okay? And that can be variably in the high 30s to low 40%. And if you're looking at...
So a third are cured with surgery.
Cured, never have another migraine, right. And then if you look at having a successful procedure as being decreasing your migraine symptoms by at least 50%. So that means that you have at least less than half the number of headaches that you're used to, and those headaches are less than half as severe as they used to be. There's some studies that show that to happen in the high 80%, some in the low 90%. But we can, in the worst case scenario, let's say 80%, but in fact it's more closely to 90%, we can decrease these headaches to be basically normal headaches. Everybody has headaches, right? So I have patients who they still have headaches, but they'll email me like a happy email. Hey, I had a headache today. I took Tylenol and it got better. That is unheard of to a migraine patient. They don't.
Right.
That's never happened to have to these patients before. So even just to celebrate having a normal headache, that's what kind of patients, that's what these patients are dealing with.
If you think about it, plastic surgery is criticized a lot for the level of data they have in studies. And these are one of the situations where we actually did a pretty good job. I mean, I'm saying that from my professional opinion. Other people may differ with me, but that's what I thought was remarkable when I was researching for this podcast.
Yeah, there's a lot of data. They're looking at 5 and 10 year data,
right,
and it's all favorable.
Yeah.
Right?
So,
but I do want to say this one thing. There are people who have the surgery that it doesn't work.
Right.
Okay,
Non-responders.
those people, right? There are non-responders out there, and so
would you think? I mean, and that's going to happen with any surgery. No surgery has 100% success in most cases. Right. But do you think some of those people have etiologies that really have not been deduced, and it's even more complicated than we think, or is that?
Well, I think there's a lot of
error?
There's a lot of different possible reasons.
Yeah.
I mean, there could be I've seen some redo operations of other surgeons that maybe didn't release the entire nerve adequately. I think that some people may have gotten this operation and not necessarily been great candidates, right? I have a particular way that I diagnose as to whether or not the patient's a candidate, and for me that's worked consistently. But there are always going to be mistakes or in that diagnostic kind of situation. For example, and we can talk about this in a little bit, but we do a local block to see whether somebody's headache gets better, whether or not that nerve is something that we can work with. And I guess there's certain people could get a nerve block and get better, but it kind of be serendipitous rather than an actual anatomic issue, and those people then get an operation, but this wasn't the problem in the first place. So I mean, I think just like any surgery, there's going to be lots of different reasons that a small subset of those people are not helped.
Yeah.
But we are fortunate in the fact that the people who are not helped by this are a very small subset.
Right, and I would say
less than 10%.
To have a surgery that, I mean, I know that I'm generalizing here, that has a 90% success rate is pretty darn good. And if I was going to implement a different surgery in my practice, I would be okay with a 90% success rate being open to the patient themselves. All right, so we're a patient. We have severe headaches. We have migraines. We go through all the treatments beforehand.
Excuse me.
That's right. And we get referred to Dr. Lowenstein, who, by the way, is in Southern California. And we get referred to Dr. Lowenstein. So what is the process by which we, as the patient, get evaluated?
So in an ideal situation, you show up in my office in pain, right? To the point that we'll talk to you before you come for your visit and say, different people have different triggers. So we talked about people with perfume. A lot of people, red wine, caffeine, chocolate, right? And so we say, the night before you come in to see me, have chocolate with red wine and a coffee chaser, and
walk by
do
the perfume counter
everything that you can do to try and come in with a migraine. So optimally, patients come in pain, which is a strange thing to say, but it is what it is. So then we have you fill out prior to this a very, very detailed history, and we want to make sure that you actually have migraines and that you actually have seen a neurologist and you actually you've had an MRI, and we know that this is the problem that we're working with. So then I'll do a physical exam, and there are about 14 nerves in the head and neck that cause, 7 on each side, that we know can trigger these headaches. And so one of the things I do is I'll just from a history try to find out where a person's headache is coming from. Is it coming from above the eye and radiating to the back? Is it coming from the back and radiating here, etc.? And we try to figure out where that is from, and I look for what's called a Tinel sign. So a Tinel sign is where you know what it is. A Tinel sign is where you tap on the nerve and you get some reaction, either increase in pain, tingling, And a lot of patients will have sensitivity to tapping or to Lowenstein in various nerves. So, okay, that's where the headache seems to be coming from primarily. And so in my practice, then what I'll do is use some local anesthetic, lidocaine and Marcaine. Lidocaine is a quick onset, lasts for about an hour. Marcaine has a little bit of a longer onset, but lasts for about 4 hours. And I will give you a shot where I know that nerve is.
Do you use like an ultrasound guidance, or do you just?
No, a lot of people do. I don't. Just from, you've operated on the nerve enough time, you kind of
know where it is.
Times, you kind of know where it is. And a lot of the ultrasounds are also used, and again, this is, a couple layers further than we're going here, but to try and find the vascular, the blood vessels that could be crossing these nerves and causing compression.
Yeah, we'll get to that though.
But basically, I'm going down to where the nerve kind of starts and giving this local anesthetic. And then we kind of turn off the lights in the room, and I go back to my office and I do some charting, and I come back in about 5 minutes. And more often than not, the patient will say, my pain has decreased from let's say they started at an 8 to X, okay? And so if they say, I had an 8 5 minutes ago and now my pain is gone, then we can be pretty certain that that nerve is the problem, and most of the problem, if not all of the problem.
Can I ask you a question?
Yeah.
So you said there's...
It's your podcast,
Yeah,
right?
thank you very much. I have only one question for you. So do you inject only one nerve at a time, or do you inject multiple areas? I mean, how do you deduce that out?
So I inject one nerve at a time, and this is what I call targeted injection mapping. So the idea is we're mapping out the problematic nerves. So when I have injected that first nerve and I come back, and let's say they say, I had an 8 and now my pain is down to a 3. Okay, so we basically start again. Now where is it coming from? Well, it was coming from back here.
Back here,
and
behind
you
the head.
fixed this.
Behind the head.
Right, behind the head. And so now it's coming from, the remaining pain is kind of in my temple or above my eye. So we look for a Tinel sign there. But even if there's not a Tinel sign, if this is where it's coming from, then we give another shot there. I leave the office, go do some charting, come back in 5 minutes. Now what's your pain? So what we're doing is trying to work down to a pain of 0, and in doing so, mapping out each of the nerves that are problematic, and in a targeted way. So that's so by the end of the consultation, you may have several injections, you may just have one. But the idea is that we're moving from severe pain towards, if not to, a pain-free state by blocking these nerves.
You're localizing the areas. Also in some of these studies, like Preempt, where the neurologists do Botox, you can Botox the areas. Can you explain, and in some of these studies they actually use Botox as the localizing agent.
Right.
So explain the difference between lidocaine and Botox in that
So
situation.
lidocaine literally blocks the nerve. Okay, it works directly on the nerve to prevent any signals from going through that nerve or back to the brain. Botox, we know Botox has some effects on the actual nerve itself, but the majority of the effects of Botox are on the muscles surrounding the nerve. And I guess we should track back and say that what we're trying to fix is nerve compression. So what we found is that compression or chronic irritation of these nerves are what are causing or triggering the migraine headache, okay? So what we're trying to do in the end point is take these compressed, tight areas around these nerves and releasing them so the nerve can be in a relaxed situation without these compressions causing this chronic irritation, causing the migraines. So by using a nerve blocker like the lidocaine or Marcaine, we're actually preventing any signal from that irritation further out to get back to the brain to cause the pain.
So even if it's still compressed by muscles, it's
the nerve can't relay those distress signals back to the brain. Botox works by relaxing those muscles that are causing the compression. And so ideally, let's talk about the nerves in the brow. So you have the supraorbital and supratrochlear nerves. And this is when people get aesthetic Botox. What we're doing is putting Botox in what's called the corrugator muscle, which causes the wrinkles and the glabella, the 11s that people say when they're frowning. And these nerves go through that muscle. So Botox often will prevent headaches in patients who have these muscles causing this compression, which is causing the migraines. So some people, instead of doing this with lidocaine, will give Botox and then assess over a period of time, because as we know, Botox it takes about 4 or 5 days to take effect. The issue that I've found with Botox is because you are adding volume to the muscle, which is already compressing the nerve, things get worse before they get better. Not always, but
really
sometimes.
Interesting, because people sometimes, especially people who haven't had Botox before, will complain of headaches after their first Botox injection.
Because that volume that you're putting in there is causing more irritation. And that's tough for the patient, because I came to the surgeon to get better, and he made me worse, right? And so, for the first week, it was a lot of phone calls, right? But a lot of those patients, after that period of time, will then find that their headaches are improved, because as the Botox takes effect, there's less compression, less irritation, less of that distress signal going back. However, Botox, again, works on muscle, but it doesn't work on blood vessels or bones or fascia, which is connective tissue. And a lot of times there are these other non-muscular things that are causing the compression. So if Botox doesn't work, it doesn't necessarily mean the surgery won't work. Does that make sense?
Yes.
Yeah, totally.
Absolutely.
But
If the lidocaine
right, doesn't work, that's a better prognostic thing in my world, that, okay, even if we block the nerve,
Right.
the
Nothing's
headache's
gonna
not
change.
getting worse, right? And I can tell you I've seen that twice, right? I mean, almost everybody that gets to me is improved by these blocks, which is remarkable, because I'm seeing a very small subset. But if almost everybody that I'm seeing is responding to this, you gotta wonder how many people are out there that are potential responders, right?
Yeah.
So
you have peripheral nerves, and those nerves get compressed, and that's what we think is going on. There are certain areas of the head that we see this over and over with migraine sufferers. Most of the time it's muscle, but it can be other things, like you're talking about fascia, or where the nerves come out of the bone itself. Just different types of differing anatomy can affect that. They come in, you use the lidocaine to numb the nerve, and if they get resolution of symptoms or an improvement, then you have a good idea that something around this nerve is irritating it. If I can go in there and release it and give it some freedom, it won't be so angry and send back painful stimuli to the brain, which then relates to this chronic problem called migraines.
yeah, I guess we're done.
Okay.
We just
All
did the
right.
whole
Yeah.
thing. Right. Exactly.
So I just want to add one thing, and it's really interesting. Science, you come on things sometimes just accidentally, and the way this all came about was that in the old days we used to do, some people still do it, but endoscopic brow lifts, where you would go in with small holes up in the hair area, and you would take out the muscles between the eyebrows, the corrugator and procerus, the ones that cause the 11s. You would actually physically remove them. And what they saw after, in a small subset of those patients who were migraine sufferers, that they didn't have migraines in that area anymore. And luckily we had intelligent physicians, surgeons, who said, well, maybe there's something around these muscles, or this muscle itself is causing something to lead to these migraine symptoms.
Yes, I agree that luckily we have intelligent people, but don't point at me. That was Dr. Guyron who really noticed that. And then he did a whole bunch of subsequent studies. And he and another friend of mine, Jeff Janis, who's at Ohio State, they did all of these anatomic studies on cadavers, finding different nerves, testing with different with Botox and lidocaine, and really figuring out which of these nerves are problematic. And we're still, again, we're in the relatively speaking early stages of this. And we may find other nerves down the line that are still an issue. But right now, we're dealing with 3 nerves in the back of the head, 2 nerves in the temple area, and 2 nerves in above the eye. And we're having good success with those.
Let's get into that. So for those listening to this, you can also watch it on video. So we're going to kind of describe it to you when we're kind of talking about different nerves, but there's also going to be an associated video with this that you can look and see Dr. Lowenstein actually pointing at, we actually have a head here.
Yeah, so...
what is his name? I have to know.
The patient's head?
Yes.
You know something? I feel bad. I haven't named the head. Right. I think Amy, maybe. No.
It's a male. It's a male.
Right. That's right. So,
or short-haired female. I don't know.
That's right.
With dark eyebrows.
Right. Well,
can I say one thing for
yeah.
just the common person out there? If most people who are listening to this probably haven't been in a cadaver lab to understand like the beautiful, delicate nature of nerves. Like when you're in a cadaver lab doing dissections and you find these nerve bundles, like they're amazingly intricate and so delicate, but they also at the same time are shockingly large in some areas of the body. Like these nerves are big.
There's a couple of these nerves that are big, and there's a couple of these nerves that are wispy small.
Yeah.
And a lot of the nerves actually branch. And so, and again, who are the non-responders? To get a complete surgical outcome, we got to ideally find each branch and decompress each branch, which can be
like a
challenging,
maze,
right?
Yeah,
exactly.
These beautiful long tendrils and just
Right.
like nerves are really beautiful.
Exactly.
Yeah.
All right, so let's imagine we have a patient and all areas are involved, okay? So, and we're going to go through, you're going to have you quickly go through the different areas, the trigger areas or the localized areas, and kind of give an idea what that patient would go through on the day of surgery, how many surgeries it would take, and the process of surgery for each location.
Okay, so let's actually move back, and we're going to call the head Thomas, because I'll tell you where there is Dr. Mühlberger in Germany and England. He has several centers in Europe and treats a lot of migraine patients. And he was good enough to send me this head, this prop, and so we'll call it his name.
He looks like a Thomas.
Yeah, there you go. So, and this, there's some of the stuff that is really nicely shown here. There's a couple nerves that are not shown, but here we can see this is the greater occipital nerve.
He's pointing to the back of the head.
Yes.
Right?
So, and that nerve comes from it's called C2, which is one of the branches of the spinal cord, and it goes through several different muscles, including the trapezius muscles, which, as we know, when we're stressed, a lot of people hold their stress in their neck and shoulders, and this nerve can be compressed by the trapezius, as well as what's called the splenus capitis, which is a deeper muscle and helps with head stability. And it can also be compressed by the occipital arteries, which are often kind of up here and now I'm pointing to the higher portion of the back of the head, and they can have arteries that cross and cause problems.
Right, so if you feel your neck and you go up to where the skull, you can start to feel the skull, that's the area that he's pointing at right
like
now.
where your
Right.
spine kind of meets up with your head.
Yeah.
Exactly.
But it makes sense why motion would be such a trigger then for people, because some of those muscles you mentioned are really key in kind of keeping our head stable.
Yeah.
Like keeping our horizon where it is. So like.
And interestingly, a lot of patients who have this problem, and when we're dealing with these nerves, we call it's called occipital neuralgia. So neuralgia is a inflammation of the nerve. Occipital is occipital area or occipital nerves. Excuse me. A lot of these patients have had either a recent or distant history of whiplash, because what's happened is you get a whiplash injury and then scarring down of the muscles which were torn during the whiplash injury, and then all of that causes tightness around these nerves. So a lot of patients that I'll talk to who've had this surgery, who are considering the surgery, I'll ask, did you ever have a car accident? I'll go, I forgot about this, but back in so-and-so, I did get into a car accident. When did your headache start? About that time, right? And so it's interesting to see that a lot of these can be post-traumatic issues. But back to these nerves, there's also here a third occipital nerve. There are three occipital nerves, and the third occipital nerve is in the same general area, just a little further down on the neck, and it innervates a much smaller area, but can also be a trigger.
So when you say a third nerve, are they branches or just three different distinct nerves?
There's three distinct different nerves,
Got
but
it.
all in
Three
the
different
occipital
spinal nerves.
region,
Right.
and therefore occipital nerves. The lesser occipital nerve actually is not shown here, but it's down in the lower lateral neck, comes out around what's called the sternocleidomastoid muscle, which is another neck stabilizer and helps with turning of the neck. And for example, for me, that's one of my triggers. So when I have a really significant headache, I'm just rubbing right on the side of my neck. And, before I knew what I was doing, I was
Relaxing.
trying to massage those areas to try and relax the muscles. And then when I learned, I progressed through plastic surgery and learned about this, oh my gosh, it all makes sense, right? So in order to get to these nerves, the way I do this is a vertical incision that's largely here in the hairline.
Right, so it's in the midline.
In the midline.
Okay, a vertical incision. Now, do you have to shave the hair?
Yes.
Okay.
We do. In women, and a lot of patients are women because more women suffer from migraines than men, we can shave the head in a manner. If you have long hair, you'd never know the difference unless you actually lift up your head. Some patients go with it and show up to my office with a partially shaved head and a totally new hairstyle. But yes, we do have to shave around the incision. And then I go down through the fascia of the midline down to the muscle layers, and then dissect to one or the other side, and without going too detailed,
too granular. Yeah.
Find the nerve, and then we trace the nerve from its deepest point to its most superficial point in what we call the subcutaneous tissue, or the fatty area just below the skin, because these are all sensory nerves. And at the end of the day, at the end of their course, they are providing feeling or sensation to parts of the scalp. So they're going up into the fat below the skin, and there's no compression there. And so we trace it to get up to that point. And back here, I'm going through the trapezius, through the splenius capitis, taking out little pieces of muscle, and also making kind of a trough for the muscle to lie in.
For the nerve.
For the nerve to
Yeah,
lie
the
in,
nerve.
excuse me, thank
Yeah.
you. And I do that for the greater occipital and for the lesser occipital. And then before we close, we take a flap, so a little kind of piece of fat that is just below the skin, and put it along the nerve to, again, prevent further scar tissue or compression from happening. So we kind of pad the nerve with a piece of
Oh,
fat.
phospholipid cushion.
There you go, right? Over for the lesser occipital nerve, I usually make a smaller separate incision at, again, down the back of the neck towards the side. And that incision is usually an inch maybe, and go down to the muscle layer. We can find that nerve relatively easily. If it's easily decompressed, then we'll decompress it. But for the smaller nerves, of which the third occipital, the lesser occipital, and we'll talk about the ones in the temple as well, these nerves really innervate very, very small areas. So sometimes if the nerve looks really bad, we'll just cut the nerve and bury it in an adjacent muscle to prevent what's called a neuroma, or an abnormal growth of the nerve, which can also be painful. Patients won't even really recognize a deficit of feeling from those small nerves that are.
But the greater occipital, you do not, because that's something that would be.
Right. The greater occipital, we can cut it. If it's severely diseased, we'll cut it. If it's a secondary operation where we've done a release and it has not been successful, but the patient is still showing us that this is still the problem, then we'll sometimes go and cut that nerve. But that can cause numbness and tingling in a larger aspect of the scalp, and that can be unpleasant.
Yeah, people find like numb scalp disconcerting.
Right. But a lot of patients, given that or the severity of their migraines, a lot of patients say, that's fine, cut the nerve. But if we don't have to cut that nerve, we try not to cut that nerve. Okay. And then we close things up. We use buried sutures, so there's no sutures to come out. Some people use a drain. I don't use a drain. And after surgery, you can be sore because we're cutting muscles.
Right, it's still surgery.
Right, but patients can tell the difference between post-operative soreness versus migraines. Excuse me, two totally different things. So patients will have soreness for a couple of days, sometimes a couple of weeks, and actually sometimes they'll have good and bad days of actual migraines afterwards. Again, the nerve has been manipulated during the surgery and is kind of angry.
Right. And you have postoperative swelling too.
Exactly. Yeah. So, some patients will have worse days, better days, and over time, over the next few months, kind of equilibrate to a situation which in more cases than not is favorable to what they had before surgery.
So in the occipital area, you make a small vertical incision in the midline. That's in the hair-bearing area. So once that heals, you're not going to see that. Right. You have small little incisions on the back of the neck, a little bit to the side, if necessary.
If you have short hair, you could see them, but they tend to heal very well.
And those go away.
Yeah.
How long does that specific procedure take, just for the back of the head?
So it takes about 2 to 3 hours if you're going to do both sides.
Okay. And then for that surgery, you'll be laying face down, which we call a prone position. It's under general anesthesia, which means there's a tube to help support you breathing. And it would be done in a surgery setting, like a surgery center or a hospital, just FYI. All right. There's other areas too. So let's talk about those.
We can take Thomas's.
Poor Thomas, he just took his eye off. If people can see this, he just took his eye off. And so what he did is now he's looking at the left eye, the bones around the eye, and then the temporal area. So if you go from your eye and you go to the outside where your sideburn is, that's kind of the temporal area.
Right. And so, the nerves above the eyelid, above the orbit or above the eye, the supraorbital and supratrochlear nerves, they go through variably either holes or notches in the bone, in the superior orbit or the eye socket. And so a lot of times there's compression there. And so we'll go and we'll actually unroof what's called a foramen, or the hole that the nerve goes through. If it's a notch, which is also common, a lot of times there's this fascia or connective tissue that's forming a bridge over the notch. We'll release that. We'll release, as here we're looking at the corrugator muscle, and we'll trace the nerves and all of their branches through the muscle to try and release these areas as well. A lot of times there's blood vessels associated with these bundles will ligate or disrupt, cut those blood vessels, so they're not a problem. And again, tracing the nerve from the deeper portion through all of these areas of potential compression out towards and to the subcutaneous tissue.
And you're coming at that superiorly. You're coming.
No, so there's two ways to do this. So there's the this endoscopic way, which is the way Dr. Guyron originally described it, and then there's it's called the transpalpebral or upper eyelid approach.
So it's just real quick. It's the same incision or the same scar you would have if you went in and did your eyelids for cosmetic reasons. So Correct. It's in the crease of the upper eyelid.
And a lot of some patients they'll say, okay, well let's get my eyelids done.
Let's get my
too,
migraines
right?
and my upper eyelids taken care of.
Right. So this is aesthetic scar, right? You're gonna end up with basically a very, very, very fine transition or a white line in the upper lid, in the fold of the lid, where people just don't see things, right? So that's a very, very well tolerated incision. And then, lateral to your eye, you have crow's feet.
Right, which means to the outside of your eye.
Right,
Everybody knows the crow's feet.
And so in here you can see this is the zygomaticotemporal nerve, which if you feel this bone on the side of your eye and then you push towards your ear, you'll see there's a little divot, there's a little depression there. And that's where the zygomaticotemporal nerve is.
Right, and if you've always seen the classic thing when people have headaches, they're kind of rubbing their temples.
Right.
They're literally rubbing right in there.
Right in the
that
nerve, trying to release that, and they don't even know that they're doing this, right? But, so we can use those crow's feet incision, this upper lid incision, and have it go into the crow's feet to access that nerve.
Cat eye eyeliner.
There you go.
Stretch that out.
Right, so we already used that incision from a cosmetic standpoint, so it's well known to heal well and not be a problem.
Very rare. I mean, I use the same incision when I'm doing mid-face lifts.
Yeah.
And so, which was interesting to me because when I learned how to do all of this surgery, like, oh yeah, I know that nerve, you'll know, is right next to the sentinel vein, right? I mean, you know exactly. You've seen. I've been looking at this nerve for years, right? But now we're doing a similar operation for a different reason. So so that nerve will either decompress through the temporal muscles, or sometimes that nerve will just get cut.
Because
again,
the distribution for sensation for that nerve, the zygomatic temporal, is small, and you can cut that.
Exactly.
Whereas the supratrochlear or the supraorbital, which again is above in your eyebrow area, you don't usually cut those because those are a little bit more.
Right, you try not to cut that. But as you know, whenever we do a brow lift or talk about doing these kinds of things, one of the risks we talk about patients is that we have that nerve cut, right? And fortunately, knock wood here, never happened to me. But one of the risk factors is that you would have a numb forehead, and we certainly want to avoid that. So those nerves, when we're identifying the nerves and actually tracing them out through the muscles, the only really way they get cut is if we're doing it intentionally, right? Because we're going in to look at the nerves, right? So
there's part of this is a little bit funny because in plastic surgery we spend so much time not cutting nerves.
Right,
we're trying to avoid them.
I mean, that's like the main complication with most cosmetic procedures.
Yeah,
you actually cut the nerve.
Right, but we also we spend a lot of time avoiding the area of the nerve.
Exactly.
Here we're actually looking at the nerve
and going in.
And so when you're looking at the nerve, it's hard to cut it unless you're trying, right? So anyway, that's.
One question I have on this, just real quick, and Dr. Guyron, in one of his discussions on his technique, talks about taking the fat from the inside portion of the upper eyelid and putting it like you did in the neck, doing the same thing.
And I do that.
Okay, for around the supratrochlear and supraorbital nerve in the eyebrow area.
Yes, and that's exactly right. So we do take some fat from the medial compartment and use it as a little flap there again to provide a little pillow for the nerve so it doesn't not subjected to.
Right. So there's a common theme here. We're going in. We, as a profession, are going in and releasing the compressing areas around these nerves, and then what we're doing is wrapping those nerves in soft tissue or fat, which allows for it to create a buffer, so you don't have this when it starts to heal and scar down. You don't have this scar effect around the nerve. Compresses it down, and you're running into the same effect. Remember, Dr. Lowenstein talked about whiplash. That's from scar tissue going down and compressing that nerve. It's the same thing in effect if you go in there and actually do surgery. And using fat grafting is really common in plastic surgery in terms of softening areas and decreasing tension on things. So fat has a positive component, and also stem cells, supposedly. Jury's still out on that. But okay, so you've done the around the eye, zygomatic temporal, which is the temporal area going near your sideburn.
And then here, there's an auricular temporal, which is a nerve that is kind of just in front of the ear. And there's a blood vessel that is often the culprit there. And so that's where sometimes we'll use ultrasound to find the area where those things cross. We can actually trace out the blood vessel and at the same time look for a Tinel sign. And where we see the Tinel sign at the blood vessel, that's where oftentimes that nerve is getting compressed. And that nerve is the easiest to get to. We can just make a little incision right. It's usually within the hairline, and dissect right down, and there it is. And ligate the blood vessel, do a little again, excuse me, releasing of the nerve in that area, or in a worst case scenario, cutting it, because again, it's really just innervating a relatively small area. We've seen that's a very common area, again, between the temporal headaches that you were discussing and people kind of massaging those areas. That's probably the easiest approach to get to that particular nerve.
Is there any other areas on the front of the face that you would address? So we have 3 areas so far. We have the base of the skull in the back, right where your neck meets your skull. We have above the eyebrow, or in the eyebrow area, the upper eyelid. We have the temporal area where your sideburns are. Is there any other areas?
And then there's the nose. So
Okay.
a lot of people will have nerves, variable compression in the nose from turbinates, which are part of.
They're outcroppings that
They're like the humidifier.
humidify the air
Yeah,
that goes to your nose.
exactly.
We've talked about actually on a rhinoplasty podcast,
We
so
talked
you
about
should
what
definitely check that
turbinates are.
out. Beauty and the Surgeon.
There you go. And sometimes your septal deviation, which you can.
Right.
So that's the
Yeah.
central portion of your nose.
The
that can
tin
be
pole
bent.
of the nose, yeah.
And so you can get compression there. So that is the other approach that we do to disrupt those areas of compression. So you'll either do a septoplasty, where you're decompressing and straightening the septum, or excuse me, a turbinectomy, where you actually take out the turbinate. But to be honest with you, what I usually do for those patients is I will send them to an ENT surgeon.
I was just going to ask if you work in conjunction with
right,
ENTs for
because I've done those surgeries. I do those surgeries, but these are not aesthetic things. These are functional things, and will a lot of times incorporate several different. People who work in the nose do a lot of nose.
Yeah, we've talked about it before. I mean, their primary job is nasal airways
Exactly.
and sinuses, so it doesn't make sense that you wouldn't send it to them, especially for someone who needs a functional improvement.
Exactly.
It has nothing to do with aesthetics. So there's 4 different areas. So when you're talking about the face, or these areas we've talked about in the face, you do that with the patient lying on their back, which we call supine. Again, it's general anesthesia. Is that correct?
Unless we're just doing a small cut down on the
Yeah.
auricular temporal, but yes, it's
Okay.
general anesthesia.
And then,
And no twitching allowed during this kind
Yeah.
of surgery.
No,
You
this
want
is right.
somebody out.
all right. So depending on the area, how much improvement can people get?
We often see no more headaches, right? I mean, you can get the entire spectrum, obviously, right? But I've seen just a lot of success in all of these areas. Patients coming off narcotics, which right now is a touchstone in this country of how
Opioid use.
opiate issues. And again, this was kind of a little off topic, but a lot of these patients are doing ER visits because their head is exploding, and something's got to be done, and they end up in the emergency room, and the doctors won't give them narcotics, right? Because they think they're narcotic seeking.
They're pain seekers.
And exactly.
Because
And-
there is no laboratory study or scan, like MRI won't show it.
Exactly.
So,
And so
you have to trust the patient's history.
Yeah, and so I've had patients who are on fentanyl patches, which is a very, very, very strong opiate, that subsequently wean themselves off of narcotics. And I try to get them almost immediately back with their pain doctor, because you take yourself off narcotics too quickly, that can be a problem. But the patients are so eager to actually be rid of these things that they start to do it themselves, right? Just great success with decreasing medication, getting people back to work, getting people back with their families.
One of the questions that I meant by that question is there more success in certain areas and less in others?
Or what percentage of
Yeah.
each type of surgery are you doing? Just one seemed to be predominant.
So-
over the
Right.
others.
That's another question I had too.
Yeah, there's the classically, this started out in the front. So it was the supraorbital and supratrochlear nerves that
The
were started out
stuff
with.
near the eyebrow.
Exactly.
Yeah.
And I know a lot of people who say whatever nerves you're doing, also go do the supraorbital and supratrochlear nerves in the eyebrow, because many patients have that problem as well. In my practice, we see a little bit more occipital neuralgia, just because I think that's kind of an emerging region. Like it's not, of all of these areas, it was the last kind of to be discovered, and now that we're seeing success with that, there's a lot of patients who have these problems back here. But I think that, honestly, the questions you're asking are very regional and surgeon specific. Like,
Okay.
I think Dr. Gairon does probably more of the brow surgery, because that was the original thing, and he fostered a very large practice doing that in the beginning. Whereas others of us, I think we're finding that a lot of patients are having these posterior neck issues, and that is kind of an expanding and growing area. And so, and as far as the efficacy or the, I can tell you my experience
Right.
is equivalent,
Right,
right?
okay.
So in all different areas.
Got
And
it.
I think, we can look at different people's experience, but again, some people are going to have better and more experience in one part of the face than the others. We're doing surgery in all of these areas and having good success.
Yeah, I think it's important to note that if you have multiple trigger areas and they're on the back of the head and the front, it's going to be two different surgeries in most cases.
So yeah, I mean, there's some there are some things. Some people will do both the front and the back. Some people will do the front then the back, and it really depends. In my practice, it kind of depends on what the patient wants and what their particular circumstances, right? And so there's some issue with operating on the back of the head and then turning the patient and putting pressure right on the back of the head
Sure.
while you're doing the front of the head,
Right,
and vice
vice
versa. But as far as getting everything done at once, it's also a very attractive thing for people. So it depends on patient to patient.
Is any of this covered by insurance?
And unfortunately,
That's
this
a
is
very
the
loaded question.
loaded question. Insurance, in my experience, will sometimes pay for some of it, okay? Rarely pay for all of it, often pay for none of it,
Yeah.
okay? And so, yeah, that is a very, very difficult thing for all of us, because, again, for me, I know what this is like, right?
Mm-hmm.
I want to operate on everybody, all right? But at the same time, I want to keep my doors open, right? So, we certainly do everything we can to help with people with financing or, whatever we can. But in the current insurance milieu in this country, they want to pay for less rather than more.
Right.
And, if you're looking at appendectomy or this, there's a lot.
Appendectomy is when you take out the appendix.
Yeah, there's a lot more longer period of time that people have been doing appendectomies than this, and so the insurance companies will often say, well, this is a experimental surgery,
Right.
and you read the data, it's not experimental. I mean, it's there's a lot of good data there, but getting the word out to the public is one issue. Getting the insurance companies is a whole other issue, as far as just having them learn about what the surgery is, how effective it can be, and as well, that frankly we're improving the costs
Yeah, it's a huge
afterwards,
cost
because
saving.
you're getting people who are going to the ER weekly, having pain doctors, neurologists, MRIs, and after surgery, that's all going away,
Yeah.
right? But that is a separate fight that we're all just working towards public knowledge that there can be help out there for a lot of people who are kind of hopeless. There are things that can be done. Once we tackle that, then, and tackling the insurance issues are
Yeah, but that grows organically. It starts with the public these days. I mean, insurance companies do offer a great service, but they're also proprietary and for shareholder entities. It's the way it goes, and you have to get the word out. People have to be informed. We talked about the whole basis of this podcast is about education and empowerment, getting someone like you on and then espousing what Dr. Guyron has developed, and Janice, I mean, this is what it's all about, and getting the word out for people that are struggling and severely debilitated is so important. And then to add on top of that, you suffer from the same thing. It's pretty gripping in terms of the story and the fact that you've done all this research and now you're actually doing the surgery. And that's the last thing I think that we need to bring up. Can you, without violating HIPAA, maybe even give us a story of someone who came to you, kind of the backstory and how it transformed their life?
So I tell you, as a resource rather than a plug, we've got some video testimonials or whatnot on
your website?
On our website,
Okay, good.
headachesurgery.com. And the other thing I want to just get in before the end here is that there's a growing number of people that are interested in this, but there are a very select number of us who are really
Proficient.
running with this and really trying to make this a big part of our practice, and that's also an issue. I mean, there's Dr. Peled, who was very instrumental in teaching me things. Dr. Afifi at my alma mater in Wisconsin, and there's some people on the East Coast. Dr. Duchik does a lot of this, and so we all try and get. We hear a lot about these patients on Facebook and whatnot, and we try to get these people in with those of us who are really really interested. Obviously, Dr. Janice and Dr. Guyron are also awesome, but there's not a lot of a lot of states don't have anybody, which is one of the reasons that I'm interested in doing some of this in Colorado, because there's nobody else at the moment doing the surgery. So trying to bring the service to as many people as possible. But I can tell you that with my practice in California, I had a gentleman, and I alluded to this earlier, from Kansas. He actually flew out for the surgery, and again, I don't know when you all are watching, but relatively recently we've had some tragedy in Santa Barbara, and his surgery was scheduled during this horrific fire that we just had. He had to go home because I had to cancel the surgery because my office was in a evacuation zone, and I'm a very conservative guy, and it was likely not going to be an issue, but I didn't want to be halfway through the surgery and have the police knocking at the door saying you have to go.
Firefighter trying to roll you out.
Right. So so we canceled the surgery. He went home, came back after the fires and the subsequent floods that we've unfortunately had. So I did his surgery. He stayed in Santa Barbara for 2 weeks, which is not necessary, but he wanted to do that.
He's from Kansas, let's be real.
There
It
you
might
go.
have been necessary for him.
Don't hate on Kansas. I mean, we're right next to it.
So I saw him just before he left, and this is a very specific gentleman. He actually has a brain tumor, a known brain tumor, a small one that he's had for years, and he had gamma knife or radiation treatment,
yeah.
and that's a 33 treatment thing, and on his 30th treatment began having headaches and severe headaches. And this gentleman is financially successful, a loving family who I've met. I mean, he's got everything you would want, including and a really, really bad pain issue. So we operated on him, and again, in the face of this radiation scarring, I told him that I'm not sure this is going to work, right? I mean, he's at the end of his rope. He had tried everything. And I said, I'm willing to try this, but you have to understand that it might not work. Before he left, he told me that he had been previously, again, planning on making appointments in Washington State where you can have assisted suicide because his pain was that bad. And he told me that he hadn't felt this good in years. And so on his way back to Kansas, he decided he was going to stop and Telluride and go fly fishing. Now, it is winter right now. You're going to Telluride fly fishing in the winter. You're tolerating some baseline pain right there in your legs. And, this guy felt so good that was, that was what he was planning and looking forward to doing. And that was just an amazing story. And, again, I just feel real thankful that I get to change people's lives in that kind of fashion. But story after story about, I used to not go to my daughter's softball games, and now I travel all over the country with her. Single parents who, you got to imagine what it's like to be a parent of a small child and trying to lock yourself in a room, quiet and dark, just because you don't know what else to do. You still have a child who's got to be attended to and fostered and all of that kind of stuff, So just getting patients out interacting with their family and friends again, and it's fantastic.
Yeah, that's awesome.
I mean, I'm completely envious of the fact that you get to help people that much.
But I think it's so important, though, that people actually know that this exists. I mean, that's so key.
Yeah, in a small way, this podcast and the associated video is going to be helpful. But I just think that starting the discussion with people, and those people there at their wits' end, that they may not be a candidate. That's the most important thing that Dr. Lowenstein said, is he's a board-certified plastic surgeon, very ethical. You need to go to people that know what they're doing. He was talking around it. You need to go to people that are specializing in this surgery. But as long as you go to someone who's knowledgeable and ethical and board certified, you should go and seek out information and advice. Make sure that you've had your full neurology workup, you've been treated, and go see if maybe you might be a candidate for one of these procedures.
Absolutely.
The downside is not massive. It's scars and some things like that, maybe some numbness in areas. But the upside could be completely transformative.
Getting your life back.
And you could be fly fishing in Telluride.
In
there
2
you go.
weeks.
There's nothing more pretty than Telluride, by the way.
Oh,
yeah.
Winter or summer.
That's true. It's gorgeous any time of year.
All right, so let's go through your Instagram handle real quick.
Yep. How can patients find you?
So headachesurgery.com is our website. And frankly, my whole thing on that website is education. So, I mean, I can't say this for sure, but I think it's the most comprehensive headache surgery website that is out there. And I am not a social media maven, but let's see, I think I'm Migraine Surgeon on Instagram.
There you go. I was kind of testing you. I just want you to know that.
Migraine Surgeon on Instagram.
There you go.
Yeah.
So, and then we're on Facebook.
I think it's under Migraine Surgeon. And then also you have a YouTube channel too.
Right.
Yeah. I think it's also Migraine Surgeon.
But all your social media links are on your website.
Yeah.
So.
Yeah, exactly. That's the best way to do it, right?
Okay.
Because, yes.
And then for us, our social media links at Jason Martin MD. If you have interest in plastic surgery, please visit ours, or actually just visit Dr. Lowenstein's in terms of the cosmetic stuff. If you liked this podcast, please rate it or rank it.
And review us.
And
share
review
it with
us.
your friends.
And then also share it with friends, especially on a topic like this where people may not know. So if you know someone who's suffering from migraines, share this podcast. Let them listen to Dr. Lowenstein, a true expert in this surgery, talking. And I'm sure if that person has questions or you have questions, you can email Dr. Lowenstein. He's like us. He'll respond back to you directly.
Yeah,
So.
absolutely. We do a lot of, Facebook has these forums of headache groups, and a lot of them are closed. And you have to kind of ask to be in them. But we do a lot of just answering questions, and I do occasionally some video question Q&A kind of things, and really educating the public that this is an option is this primary interest of all of us that are really doing this surgery.
Well, thank you for doing it. And I would be remiss if we didn't thank the head.
Thank you, Thomas.
Yes.
Thank you, Thomas.
Thank you very much.
Are you going to put his eye back on there?
Yeah.
Okay, that's good.
I was feeling a little nervous about that exposed surgical site for so long.
Dr. Lowenstein, thank you for coming in. Also, Dr. Lowenstein is expanding into the Colorado area, so you can feel free to call our office and get more information on that.
That's right.
Thank you, Dr. Lowenstein.
Thank you. Thanks for having me.
Thank you.
Pleasure. Always.